Thanks, everybody.
Yeah, thank you for your patience as we figured out our tech issues.
Yes, thank you so much. We're really glad all of you are here. And again, technology is our friend until it's not, which you always learn, unfortunately, when webinars are supposed to start. So apologies for a little bit of a delay here, but super excited about our speaker today. You know, we always try to bring national experts to talk, and a lot of you have, you know, and continue to bring up questions around ADHD. And what can I do? I'm in collaborative care. I have, you know, someone that tells me they have ADHD. Like, how do I really build it in? How do I know it's ADHD? And so one of the things that I love about our speaker today is he can really answer all those questions and really give us some pretty good guidance. So Mina, I'm going to turn it over to you. I'll let you introduce yourself and take it away.
Thank you, guys. And Verna, Elizabeth, and Amy are being generous and not mentioning why we were late. That it's on me. The electricity went out briefly and resulted in delays on that front. So it's a pleasure to be here virtually, to be talking to you all and to address a topic that's near and dear to my heart. ADHD management. Today, I'll try to sort of bookend the discussion you had. I'm not sure if it was last week or last month about executive dysfunction, and extend that to the discussion specifically of ADHD and how to manage the condition. About me, I'm a psychiatrist and clinical informaticist at Animo Sano Psychiatry. I started the company a couple of years ago and have been the medical director at the company for the past couple of years. We're a growing regional practice that focuses on general behavioral health. We do have an ADHD subspecialty clinic that I started after my time at Duke, where I started an adult ADHD clinic there. In addition to that, we do work in collaborative care and really enjoy our effort there. A few fun facts. As far as disclosures, when I put this together, there weren't any active disclosures beside my ownership of ASP. As of yesterday, I will put on that I do consulting with GLG on occasion, and I had a consulting contract just come up, but they're rare and they're unrelated to this work. Fun facts about me: I have 2 young kids, 2 dogs, and lately I've just been trying to find a way to do a child-friendly activity that also keeps me, a child at heart, entertained. And if you guys have ideas, I'd love to hear them.
I'd love those ideas too. So.
So as far as our objectives, we'll start by recapping the discussion on executive dysfunction. We'll introduce ADHD. As we're going through our discussion about ADHD, we'll talk through some of the common myths and facts about ADHD. We'll go through some of the prevalence information and talk about approaches for management of ADHD and what you all could specifically do as behavioral health care managers in managing patients with ADHD. And there'll also be some discussion about managing providers who care for patients with ADHD. So the last time you all talked about executive dysfunction, and just as a reminder, what executive dysfunction is a set of skills that enable planning, organization, and follow through. Certainly attention, working memory, cognitive flexibility, inhibitory control are all part of that. I like to think of executive function at its highest order being the ability to delay gratification and manage your present responsibility. Common challenges include the things you see here: impulsivity, disorganization, difficulty initiating tasks. And there are multiple conditions that lead to executive dysfunction, not just ADHD, but certainly depression, anxiety, just active stressors could lead to executive dysfunction. Where the dysfunction lies is in my inability to address my daily responsibilities and requirements, and the relationship of my executive skill set to that inability is what then leads it to be called executive dysfunction. You know, I think to some extent, as a society, we've been reducing the threshold by which we apply the executive dysfunction label, because the mold that is our culture, or the mold that is our culture, is increasingly requiring more of us. And if we don't fit that mold, truly that leads to significant consequences. Perhaps in previous times, the threshold to label someone with executive dysfunction and the things that cause executive dysfunction would have been higher, just because there wasn't as much expected of an individual. So I think to keep in mind, it doesn't negate the reality that people are suffering despite our lowering the threshold. It doesn't negate their experience or the need for treatment. Unfortunately, this is the reality of our present time. We live in a culture that expects more and more of individuals, and consequently, what is normal has been to some extent shifted. You guys also talked about assessment approaches and setting up clients for success. So certainly in evaluating a patient with executive dysfunction, you do want to do a comprehensive evaluation, evaluate the cause of executive dysfunction, and in sharing behavioral strategies with them to target their symptoms, the key thing is no more than 1 to 2 things at a time. I saw in the previous presentation a statement about less is more, and it really is. You could share the kitchen sink with someone, and you're just going to put someone who's already has executive dysfunction in a state where they have to determine what it is they need to do, when it is they need to do it, which of the elements are best suited at which time. The best thing you could do is offer 1 to 2 strategies and let them work with them through the course of weeks, see what works, what doesn't, and add to that over time. As far as strategies for planning, organization, and task management, I saw that you guys talked about SMART goal setting. I love SMART goal setting. Remember, specific, measurable, attainable, relevant, and timely. They're fantastic ways to set goals for individuals, and teaching people the importance of SMART goal setting is can have significant benefit. The Eisenhower matrix, the urgency and importance matrix, as you guys might remember, is also very rich and good to use. And you're using one of these things. If you're teaching a patient, you're not teaching all of these things. And then talking about breaks and or chunking tasks and approaches to task initiation is also very important. I know later on we'll also address the concept of using the Pomodoro technique to really manage one's time well. Mindfulness exercises, breathing exercises, stop, pause, and think to address impulse control, all of that important skill sets and techniques to lean on when you're working with patients with executive dysfunction, including patients with ADHD. The reason I'm going fast through these set of slides is because I know you guys have covered them. I'm just recapping them. And as a reminder, or at least based on what I saw from the notes from the last lecture, it looks like you guys also have toolkits on these. So do use the toolkits that were shared with you. And then strategies for self-monitoring, the Pomodoro technique, a great one. And for those that may have forgotten, Pomodoro is a technique for splitting work and rest time in a fashion that allows you to succeed. So the way it's originally conceptualized is 20 minutes of work, 5 minutes of break, but you could arrange that to the patient's need and to what is realistic to the patient. Using checklists, a consistent tool, oftentimes in managing or working with my ADHD patients, I find that they already know of many tools, and they're one of the distractions that end up taking up much of their time is working to find the perfect solution, the perfect tool, and going through from Todoist to paper and pen to some other application. One thing I like to remind my patients is the imperfect solution utilized consistently is better than the perfect solution utilized never. And the goal is to use something consistently to manage my day-to-day responsibilities. I will put in a quick word for those of you who are interested for a book series or a book called Getting Things Done by David Allen. It's sort of become its own culture, the GTD culture. I really like David Allen's approach to task management. It does have elements of smart goal setting to it, chunking, and adequate utilization of checklist management that I think is wonderful. I'd recommend it for you, and if your patient is looking for a read for your patients as well. So that's our recap. You talked about executive dysfunction, you know what executive dysfunction is, and different approaches to helping patients with executive dysfunction. So what is ADHD? ADHD is a condition that develops in early childhood that leads to executive dysfunction. Its predominant set of symptoms are executive dysfunctions. And then there are elements of mood, delayability, irritability. The impulsivity specifically relates to the executive dysfunction. And what does it mean that it's a neurodevelopmental condition? It means, like I said a moment ago, it starts in childhood, or at least symptoms begin to manifest in childhood. The DSM cutoff is specifically there need to have been symptoms before the age of 12. Does that mean if a patient comes to you as an adult and says, I struggle with these executive function tasks, and that struggle sounds like it leads to the point of dysfunction, does that mean that, but I haven't had symptoms prior to the age of 12, does that mean that that patient isn't suffering? No, but what it does mean is that they don't have ADHD, they have executive dysfunction due to something else. Does that mean that that patient can't be treated? Absolutely not. They can definitely be treated. And for many patients with executive dysfunction, so long as the source doesn't have, the cause doesn't have some other clear intervention, the common interventions we use for ADHD would also work for those patients. So just something to keep in mind. The caveat to that, though, is if a patient presents with report of executive dysfunction in adulthood and says that that executive dysfunction preceded the age of 12 and the history aligns, then they may in fact have ADHD. So the statement I said earlier was more in relation to the patient who did not have symptoms prior to the age of 12 and the symptoms truly presented after the age of 12. Based on my experience, that represents a minority of adult patients, but it does represent, they do end up showing up. So the symptoms need to have started before the age of 12, and they need to occur in at least 2 areas of life. And of course, they need to result in distress or dysfunction. Now, before I go into more detail about the diagnosis of ADHD, I want to address a unfortunately common myth. I was actually looking at the numbers in terms of public perception of ADHD being a real disorder, based on a study that was done in the late 20-teens. And it's something like 40% of the public does not believe ADHD is a real condition. It sort of falls pretty low in the totem pole as far as behavioral health conditions in terms of belief of it being real. There is no question about ADHD being a real condition. The ADHD actually represents one of the most commonly studied and published on conditions in the world of psychiatry. In the world of psychiatry, in the world of medicine. Of all conditions, ADHD happens to be amongst the top as far as studied conditions. Of the studies, the vast preponderance of them equal to the rates for other conditions point to the legitimacy of the condition and the benefits of treatment for the condition. They also point to the significant consequences that occur in individuals' lives when they go untreated, some of which we'll talk about. So I hope that this myth clearly comes across as a falsehood to you all. Most certainly, if it doesn't, hopefully some of what I'm going to go through points to the reality of ADHD being a real condition. If not, then I've failed to do my job in at least conveying that. There's lots of biological evidence for the existence of ADHD. Amongst that include the heritability studies showing the condition to be anywhere between 77 to 88, I think it was, percent heritable. At those numbers, ADHD would be, if we're talking on the lower side, the second most heritable behavioral health condition. If we're talking on the upper side, then the most heritable behavioral health condition, based on current evidence. It certainly has the most evidence for single nucleotide polymorphisms, demonstrating its genetic predispositions. So very much so a highly biological condition, so not just environmental, and highly heritable. So going back to what is ADHD, we went through this slide, so I'm going to skip to the components of ADHD. So as a reminder, it's a neurodevelopmental condition, meaning it must have occurred in childhood before the age of 12, according to the DSM-5. There need to be a subset of inattentive and or hyperactive impulsive symptoms, which we'll go through. Those symptoms need to be present in 2 or more areas of an individual's life, and they need to cause dysfunction in at least one of those areas. As far as the inattentive symptoms of ADHD, the way I like to think of them is by sort of organizing my mind around task management and then the non-task management subsymptoms. And the DSM-5 has 9 symptoms in specific. And if we're thinking about task management, what do you need to do? And to be clear, I think about the symptoms as relating to task management because that's sort of the pseudo-mnemonic that I use in my mind. But these symptoms don't just specifically impact task management. So the way I like to think about it is organize. What does a task require? It requires organization. It requires initiation. So those are 2 of the symptoms. It requires you to be able to attend to the task such that you're not making careless mistakes, to sustain that attention on that task. So we've gone through 4. To not get distracted by external stimuli, that's 5. And it requires you to finish that task, that's 6. So ADHD results in challenges in all of those areas: difficulty with organization, initiation, what we commonly call procrastination, difficulty with making regular careless mistakes and not following through on instruction, difficulty with maintaining attention on the thing at hand, difficulty with your mind just being pulled away by external stimuli, and difficulty not getting the last little bit of the task done because of boredom, typically because of boredom. And then, so those are the task ones. And then the other ones are the other ones. And you see the other ones there. It's forgetfulness, losing things regularly, and difficulty maintaining attention in conversation or difficulty listening. So those are the inattentive symptoms. Of my adult patients, and I'm predominantly treat adult patients, but I have an adolescent mixture as well. The most common challenging symptom for them, if they're coming because of challenges at work or school, typically relate to procrastination and not getting things done. If they're coming due to challenges at home, it partially relates to that, and then partially relates to discord with family members, with spouses, about being overly impulsive, not participating in conversations or common household chores. So the hyperactive impulsive symptoms of ADHD, there are also 9 of them. For your adult subset of patients, I've highlighted the common ones for adults. Often you're going to see them fidget a lot. They're going to have the difficulty playing or engaging in leisure activities. Think about the person that you sit down with to watch a TV show or a movie, and within a couple of seconds or maybe minutes, they're up off of their seat and doing something else. They've already lost attention and are on their phone playing whatever video game they're doing. They're just unable to maintain a presence for what would be normal for most of us. They're often feeling on the go and acting as if driven by a motor. So how does that present in adults? In childhood, that's what it sounds like. The kid's just constantly up and down, up and down. In adults, it typically presents as an internal sense of, I need to be doing something. I don't know what it is, but I just can't sit still. And that also is what leads to some of the other symptoms we're talking about. They're often talking excessively, interrupting others, and the last 3 there really relate to interruption, and that's how they present. The impulsivity, so outside of these symptoms, there is a level of impulsivity around shopping behaviors, around interactions with others, making assumptions about what someone was meaning and possibly saying something hurtful as a consequence of that. That is often seen in ADHD, even though where we don't directly discuss that in the 9 hyperactive impulsive subsymptoms. It is not how you differentiate that from bipolar disorder. Is it's impulsivity due to a misunderstanding, or impulsivity due to an ability to delay gratification in the here and now that isn't persistent all the time, constantly, and isn't over and above within that mood disorder window, and isn't over and above what is normal for the individual. So they are chronically impulsive, as opposed to in this 2-week, 1 month, 3-month period, they just suddenly and markedly changed from their baseline. I do want to go through the next set of slides, but before I do, any questions so far, comments or concerns? Or are we saving questions till the end?
No, actually, there's some, and I was going to say, curious about the difference in presentation for women versus men. I thought maybe you might want to take that on.
Yeah, that's a great question, and the answer to that is coming up in the next set of slides if we could wait.
Perfect. So then we will wait. And one more, maybe, if we want to take now. Curious how technology has affected ADHD. Do we see an increase as we are required to focus and absorb more info than before?
Yeah, great question. So like I said, so ADHD as a condition has certainly been affected, but I want to talk about executive function and executive dysfunction in specific. So if we think about all of humanity, all individuals existing on some level of continuum within the executive functions, let's use attention and working memory briefly. There are some individuals who are able to hold incredible amounts of attention to a particular task. Sometimes that could lead to its own dysfunction. And then as you go down the line, there are going to be individuals who are able to hold less attention, all the way through to the extremes of inability to hold any attention at all, possibly due to some form of stroke. If we think about the average individual, we fall on a bell curve. And to some extent, where we fall on that bell curve gives us resistance to the distracting influence of present technologies. However, as technologies evolve to steal away our attention, as they evolve to influence our dopaminergic reward system such that even when we're not intending to, we find ourselves going to the YouTube shorts or TikToks, they will be able to impact our attention in a fashion that results in executive dysfunction because we no longer fit the societal mold and requirement to stay on task and address my responsibilities at work. That certainly is true of every human. There is only so much resilience that we can have to the technologies that are being developed to steal away our attention. That's the purpose of many of the technologies that exist currently. Attention is the commodity. So that's true of every human. And imagine then this ADHD subgroup that already struggles with executive function and has less resilience to these tools. So most certainly you're going to see more dysfunction. There are other things that I've seen to be a challenge. So even though many individuals have reaped the benefits from work at home culture and found themselves to be able to manage more, I found in my ADHD patients that for many, work from home culture has actually resulted in increased challenges, because what keeps an individual with ADHD accountable to their work is knowing that, unfortunately, as much as it's not fun to know this, knowing that there's someone around who's going to see them slack off if they slack off. So there is a sense of, there's this curve called the Yerkes-Dodson curve. And according to that curve, angst or anxiety or stress has a bell curve relationship with productivity. For the ADHD individual, if that angst isn't at a certain optimized state, then their productivity starts to decline. And you could think about the curve as being narrower, such that if it's even slightly unoptimized, then they fall extremely and the productivity dissipates significantly. That's not to say that if someone has ADHD, we should teach them how to get anxious about work. We need to work with them on additional strategies, but that's been a challenge I've seen from work from home culture. I'm, by the way, a fan of work from home culture and a proponent of it. I just think for some patients it doesn't, or for some individuals it doesn't work out quite as well. Okay, so I'm going to go into DSM-5 criteria. So we talked about the 9 inattentive symptoms, the 9 hyperactive impulsive symptoms. What the DSM-5 requires is that a patient, if you're seeing a patient as an adult, they must have 5 of the symptoms within the cluster. So if they're ADHD inattentive subtype, 5 inattentive symptoms. If they're hyperactive subtype, 5 hyperactive symptoms. Or if they're combined subtype, 5 of one and 5 of the other to meet criteria for diagnosis. And they need to have had symptoms prior to the age of 12. The symptoms need to be present in 2 or more settings. There needs to be dysfunction in at least one of those settings. The thing to note, though, is they need to have 5 or more symptoms present in the here and now, the past 6 months. If you're going by the DSM-5, the patient is unlikely to be able to remember 5 or more symptoms in their childhood. Typically in my screening and evaluation of patients, if I'm speaking to them or family, I'm just evaluating, were there executive dysfunction challenges in their childhood? And if I'm hearing 2, 3 or more symptoms, I'm thinking, yeah, they did have challenges in childhood. The mere fact that they remember something as an adult that occurred prior to the age of 12 likely means it was significant enough as to result in that memory. And then I'm screening for the present symptoms. Another key consideration, so the DSM-5 requires what I just shared with you. If you read a little bit from the writings of Russ Barkley, who's one of the major researchers in this space, he would advocate particularly for the hyperactive symptoms, given that we as humans tend to punish hyperactive patients a little bit more. So the negative reactions to when they're jumping off the walls as a child are more severe than the inattentive symptoms. Patients consequently internalize those symptoms. So it's going to be harder to find a patient who has 5 or more symptoms despite having hyperactive symptoms. So usually if I'm hearing 3 or more hyperactive symptoms, I'm considering the hyperactive subtype. Realistically, the vast majority of patients that are going to come in through your door are going to be inattentive subtype or combined subtype. From a treatment perspective, for the most part, the treatment is the same. Perhaps there are some additional behavioral techniques you're going to consider if hyperactivity is a challenge. But if you are addressing patient symptoms, really, you're not necessarily looking at the cluster of symptoms, but you're addressing just one of the symptoms. So if one of their challenges is difficulty with interrupting others regularly, working with them on mindfulness techniques, stopping, planning, and acting, or just a 5-second pause technique. You're not treating hyperactivity alone, because that's such a broad category. Ditto for inattention alone. So let me go on to the next slide. And we talked about the specifiers. ADHD does come in mild, moderate, or severe forms. The DSM-5 is a little bit, well, I shouldn't say light on the way they define mild, moderate, and severe. Basically, mild is just meeting criteria. Severe is meeting most of the criteria, and moderate is in between. I kid you not, that is more or less the DSM-5 definition of mild, moderate, and severe. I mentioned earlier there will be some adults who come in and say, hey, I've developed symptoms in adulthood. I didn't have them as a child, and they're fairly confident about that. Those are likely individuals with executive dysfunction due to something else. And that doesn't negate the fact that they're suffering, and it doesn't negate the fact that there will likely be treatments for that something else. You just need to determine what that something else is first, or to help your PCPs determine what that something else is. A subset of adults who do not recall symptoms before the age of 12 may in fact just have had a lot of support. So I would ask about some of these elements. How much support they had in the household, how much involvement their parents had in helping them with completing their homework. Did they really have anything in the way of chores? If you hear there's been a lot of support and they really started struggling when they moved off to college, that's pretty common to see in individuals who have had ADHD but were diagnosed later. High IQ allows for early life compensation, and if you look at the rates of ADHD diagnosis across IQ, you see that as IQ increases, it's really later on in life that a diagnosis is made for ADHD. Support, good structure and routine, and then the adult onset component, as in symptoms truly started in adulthood. We talked about that could be one of a host of many other conditions. Okay, this next item is really important to me, and that's that the myth that ADHD can only be diagnosed via neuropsychological testing. I can't emphasize this enough. That is a myth. It is inconsistent with all of the guidelines that I know of, and there have been studies to evaluate the guidelines that have demonstrated the guidelines to not currently recommend neuropsych testing for the diagnosis of ADHD. You can use it to evaluate for comorbidities. You can use it to evaluate for specific cognitive functions if you're thinking about intervening at a cognitive function level, which we don't really have very many interventions at that level. And the only other instance where I would be thinking about using neuropsych testing is if a patient is looking to get accommodations from organizations that require it, despite the guidelines not requiring it. And that typically relates to specialty level board examinations, where I've seen that. Most institutions nowadays don't require neuropsych testing as well. There have been studies on evaluating the guidelines on the management of ADHD, and what you find is across the vast majority of guidelines, neuropsych testing is not a first-line evaluation method for ADHD. And even the European guidelines, which were, I think, since last updated in 2018, have changed to not requiring neuropsych testing. And the reason is that while neuropsych testing is good for evaluating for specific cognitive functions, historically, we thought they were also good in catching the malingerers, the people who are making up symptoms. Reality is neuropsych testing is actually good at misdiagnosing individuals who are looking to feign symptoms. So it's not good at catching malingerers. And it's more likely to miss individuals with true symptoms than it is likely to catch the malingerers. And you'll see in terms of sensitivity and specificity profiles, some of the neuropsychological tests just don't quite, there is no 100% sensitivity and specificity. Just as an update, sensitivity means the higher the sensitivity, the more likely I am to catch someone with the condition. And the higher specificity is the more likely I am to rule out a person who doesn't have the condition from having the condition. So the ASRS and the DIVA here are just structured interviews, and you'll see the ASRS screener, which screens for the condition, rightly has a very high sensitivity, a low specificity, but it doesn't need to have a high specificity because it's not diagnostic. The provider's evaluation is what should lead to the diagnosis. That's the gold standard. The DIVA, on the other hand, does have a high sensitivity and specificity, but does require quite a bit of time to administer, whereas most of the neuropsych testing options have lower sensitivities and specificity, certainly than the DIVA, and in many instances, lower sensitivities than the ASRS screener.
So Doctor, I'm going to jump in 1 second because there's 2 questions in the chat. So maybe we take them now. I just also want to be mindful that we'll have time for questions My question is, with ADHD in children specifically, what are some of the first alternatives to manage it prior to medication?
So in children prior to the age of 6, the current American Academy of Pediatric guidelines recommends using parent-child intervention training, which is essentially a nice way of saying we're going to train the parents to better address the needs of the child, because we're not trained to do that as parents. No one had a session with me to tell me how to parent my children, and I've had to learn it as we go along. PCIT just helps expedite that process. There are certainly other considerations for early life diagnosis of ADHD, depending on any association with food intolerances. You might want to do food sensitivity testing to rule out the possibility that this in fact is an allergy. The jury on food dyes is still out. There's some data showing that it might contribute to worsening symptoms. There's some that shows maybe there is no relationship. But also therapy. There is some evidence for the role of, oh my gosh, essentially EEG-based training for the benefit of symptoms. Based on my review of that data, I struggle with whether or not it's the training or the training has significant impact on executive dysfunction broadly, or it's specifically training individuals to do better on the neuropsych testing, essentially, because it's done based on ATOVA, which is a specific type of test that requires attention to a computer, and the training also requires attention to a computer.
Yeah.
But once you exceed the age of 6, the gold standard of care, presuming you're confident in the diagnosis, is actually stimulant medication. Stimulant medication combined with psychotherapeutic intervention.
Yeah, and actually many payers will not pay for a non-prescriber to have ADHD as a primary diagnosis because of that. You often see denied claims. I just want to be mindful. We only have 11 minutes left, so I'm going to give you one more question, then we'll let you go, and then maybe we'll stop 5 minutes. So just because there's several questions here. I'm presently working with a client who used to self-medicate to control her symptoms in the past. Any advice on recommendations in regards to helping her keep on track?
So who used to self-medicate to control her symptoms in the past? It sounds like there needs to be multiple interventions there. First, connecting the client with an expert provider who can evaluate what it was she was self-medicating for, because there's a possibility that the client may be self-medicating something other than ADHD. In addition to that, if her symptoms were bad enough as to require self-medication, she likely would also benefit from a true pharmacologic intervention, depending on her substance use level. That may be stimulants, that may be non-stimulants. In addition, this sounds like a client in which motivational enhancement therapy is necessary to bring her awareness of the active problem. And the active problem may not be the ADHD, it may be a substance use disorder. And promoting her movement towards a treatment that will help that active problem. And in substance use disorders, my go-to is really trying to move people towards at least initial participation in groups once they've come to reality of the situation, and how is it that we minimize use. So a sort of two-for answer there.
You mentioned a type of therapy. I just want to go back and ask you to elaborate, because there might be people who might not be familiar.
Motivational enhancement therapy?
Yes.
Okay, so motivational enhancement therapy is essentially a form of therapy that focuses on promoting the patient's autonomy and respecting their ability to come to reasonable conclusions about their well-being and treatment. So the way it works is as a true and honest conversation about what are the problems in your present life. And maybe I, as the provider, have the bias of believing that substance use is a problem. And I would honestly bring up, I'm hearing you talk about XYZ in relation to the substance use. I might prod in a little bit more to see if they believe that there are problems around that. And it may very well end in the patient saying, actually, my daily alcohol use is not a problem. And to some extent, all you could do is acknowledge that you guys are on different pages, and that's okay, so long as you are not doing anything to bolster their misuse, and none of the medications their prescriber is prescribing is resulting in increased worsening outcomes. Then you continue to have that conversation over time to try to see if you could shed light on a potential problem.
Nice.
That's a bastardization of motivational enhancement therapy.
Well, I actually maybe we'll send something out. If a child has a genetic predisposition, are there ways to help increase the brain's capacity to sustain attention? That's a great question.
Yes. So that neuromodulation is the EEG treatment that I was talking about. So the many of the proponents of, sorry, not neuromodulation. Now oh my gosh. I'm blanking on a very common treatment. Many of the proponents of the EEG attention developing treatment that
Like
neurofeedback. Thank you, Verna.
Someone helped you out in the chat. Actually, we were both coming to your rescue there.
Would say yes. And to some extent, we do see improvements in an individual's ability to attend to responsibility, or not to attend to responsibilities, to attend to specific tasks by practicing attention to that specific task. In fact, there's multiple studies done on this particular topic, but in one area that I like is dual end-back training. Individuals do wonderfully well in terms of improving their working memory, specifically for dual end-back. Whether or not that has far-reaching effects outside of the specific task is where I think the jury's still out.
So there's a question around, talk a lot about parents and children. As a manager, what strategies would you employ for an employee with ADHD?
So I would try as best as possible to build in as many reasonable accommodations for them that will help them succeed. There are, and that includes working with their direct provider if they're comfortable allowing for that, to identify what the provider feels would also be of benefit to the patient. There are a few challenges there. So for instance, I mentioned that accountability improves function in the workplace for individuals with ADHD. So part of that entails doing things like asking the individual to share a working plan for the week and to share the outcomes of that plan at the end of the week, prior to and at the end of every week. And if their symptoms are particularly bad or challenging, I shouldn't use words like bad, you might do that on a daily basis. And specifically, so a reasonable accommodation there isn't the requirement to do that, but to give them time to do that. So at the beginning of every single one of your days, I want you to take time from your schedule, 10 minutes, 15 minutes, to tell me what you're going to do. And at the end, take 10 to 15 minutes from your schedule. So your work in that specific time is to tell me what you did. That improves work However, how you present that to the employee is incredibly important, because that could come across as punishing when in fact you're looking to implement a system to help them succeed. Because the alternative is, if they're not succeeding in the workplace, they might not be able to retain the job for an extended period. It's hit or miss in terms of individual responses to systems like that. Certainly, there are many other systems to leverage, but I'm a company owner and have leveraged similar systems, and have also spoken with my patients about working with their employers to do similar things for themselves.
Mm-hmm. So since we only have 2 minutes left, I'm going to give you the last question because I think it's a good one. And then maybe we have you come back to finish and we schedule you again if you're open to that. So I struggle with frustrated parents, getting them to have empathy for their child who's often struggling at school and been diagnosed with ADHD. Is there a way that you found effective to describe ADHD to parents?
That's a loaded question. So I think so we just talked about ADHD being highly heritable. And what that likely means is that child you're managing has parents who have ADHD. So already they're individuals with low impulse control, increased likelihood for irritability and mood lability. Individuals who are likely to struggle when life gives you curveballs or lemons, it's going to get. When life gives you curveballs, it's going to give you many. Or when it rains, it pours. There are individuals who are already going to struggle with managing a child without executive dysfunction. Now imagine a rambunctious, high-energy child who has, a scale of symptoms, and on the severe ends, it's going to make it real challenging. So amongst the things that I do is I psychoeducate. I talk about the condition. I try to come to the session with a certain level of confidence about the presence of the condition, because the confidence that I convey in the presence of the condition eliminates concern in the family member of the reality of the condition, and it sort of opens up their empathy. My child, my spouse has a real condition, and this condition leads to these problems. And then I talk about specific examples. What have been the challenges that you've been facing in your family? I link those challenges to the condition, and then we talk about solutions. So if amongst the challenges is organization and task management, then we're putting up a whiteboard in the kitchen or wherever everyone is going most, and we're putting all the chores on the whiteboard. And I'm asking the family to get involved in that process, so that the child or the spouse is seeing the whiteboard and checking off the things that they're doing as one of many possible interventions.
Love that. Okay, so we are actually just going over time. There's more questions, actually. I think maybe what I can do is just talk to you and maybe we can have you come back and finish slides and answer more questions. And actually, I'm thinking, just given the number of questions, some are coming to me also, is that maybe we schedule half of that time to just do like a Q&A. Because I feel like there's just so many questions around this, and I feel like we didn't even get to sort of what do I do. So you're getting quite a few kudos in the chat. So maybe you and I can just chat offline and we'll figure out a date for that.
Absolutely. And I'm sorry, guys. I only went through half the lecture. I often find myself overestimating what I could cover.
I also think it's just about the passion and the questions and some of the real-time examples. Like, what really benefits is I can leave here and do something different, have different language, have different information. And that's really what we strive to do. And yep, people are saying, hope to have you come back. So we're going to work on that. Well, thank you, everyone. Have a wonderful day, and we'll follow up.
All right. Take care,
Thanks.
everyone. Bye-bye.
Bye, guys.
Thanks.
Thank you.